Hi everyone, it's our next section. This is myocardial disease. This is Conrad Fisher. Basically, myocardial disease means just a myopathy of the muscle. It means that the muscle is not working normally. It means that the muscle itself, separate from coronary disease, separate from valve disease, the muscle is defective. That's what the term means, myocardial disease. In other words, it's not dead muscle from coronary insufficiency. It's easy to understand that coronary insufficiency kills off the muscle and doesn't move. But what happens when the muscle just doesn't move because it's just abnormal? It's easy to understand left ventricular hypertrophy that eventually dilates with aortic stenosis. But what happens to cardiomyopathy where the myocardium becomes hypertrophic then dilates up with a normal valve? That's what this section is. What's the diseases of the myocardium that occur in the absence of coronary disease, in the absence of valve disease? It's an intrinsic muscular disorder of the heart without being from something else. Most cardiac disease is from coronary disease. It's from valve disease. Primary myocardial disease is much more rare. That means it's a defect in the myocardium happening simply on its own. The classification is according to its size and whether or not it's hypertrophic, dilated, or restrictive. We'll go through each of these. The characteristics of dilated cardiomyopathy is just what the word says. Dilated cardiomyopathy and systolic dysfunction are virtually synonymous. There's biventricular dilation, and the left ventricle and the right ventricle both dilate. There's a decreased cardiac output in everything. As a matter of fact, if you can find me a person who has a disease that makes the cardiac output go up, we wouldn't call it a disease. We'd call it a good thing. So everything here makes the cardiac output go down because, after all, it is a disease. The stroke volume particularly goes down because this is a person whose myocardium can receive blood but can't eject it, and the filling pressure is up. Hypertrophic cardiomyopathy, you've got to make sure that you understand there's a difference between hypertrophic obstructive cardiomyopathy, because hypertrophic obstructive cardiomyopathy is an abnormal piece of septum in the way. That's an abnormal piece of septum that's blocking the myocardium, it's blocking the exit of blood out of the left ventricle. But this hypertrophic cardiomyopathy is most often from good old-fashioned hypertension. Yes, I understand amyloid and hemosiderin can do it at the beginning, but it's just good old-fashioned hypertension. Restrictive cardiomyopathy is sort of the worst of both worlds. It's a heart that doesn't dilate and doesn't contract. See, dilated cardiomyopathy relaxes, but just can't contract. Hypertrophic can contract, but it can't relax. Restrictive cardiomyopathy doesn't do either one of them. It just lies there. Restrictive cardiomyopathy is from sarcoid, amyloid, hemochromatosis, cancer, and fibrosis. That's restrictive cardiomyopathy. Dilated cardiomyopathy is defined as a diminished myocardial contractility. It's usually involving both ventricles. It can be the most common cause of a heart transplant. In other words, it's not caused by heart transplants. What leads to the need for a heart transplant is a person with a dilated cardiomyopathy that doesn't get better in symptoms with maximum medical therapy. They're on ACE inhibitor, they're on digoxin, they're on a diuretic, they're on a beta blocker, they're on spironolactone, and they still have symptoms. Transplant me. The etiology of dilated cardiomyopathy can just happen. Idiopathic means that there probably was a viral myocarditis that just was never detected, and they show up as a dilated cardiomyopathy later on. In addition, there's alcoholism, peripartum cardiomyopathy with persistent LV dysfunction. Peripartum cardiomyopathy with persistent LV dysfunction is the single greatest mortality to a pregnant woman. Peripartum cardiomyopathy with persistent LV dysfunction results in death in 50 to 70% of women who become pregnant again. That's the only thing that's worse than Eisenmenger's in pregnancy, is persistent peripartum cardiomyopathy with LV dysfunction. The post-myocarditis is really the one that's infectious. That is the one where viruses and parasites and other organisms just invade the myocardium and cause damage. In addition to cardiomyopathies from infection or alcohol, the other toxins like cobalt, lead, or arsenic, or medications like daunorubicin, doxorubicin, adriamycin, cyclophosphamide, vincristine, or the metabolic abnormalities. Low phosphate makes all muscle abnormal. Low phosphate or low calcium, or metabolic problems like hypothyroidism or selenium deficiency. Not just thiamine, but selenium deficiency. Zap your myocardium. Well, why break this up? Why have a dilated cardiomyopathy section? Why not just go with what we said in the congestive failure section? Because these are the ones that are not from coronary disease or valvular disease. It's saying, what's the dilated cardiomyopathy that's not from coronary disease and not from valvular heart disease? The good news is, if you've gone through the other sections, you will already know much about the testing and treatment. The manifestations of dilated cardiomyopathy are the same signs and symptoms of heart failure that was seen in the congestive failure section. Pitting edema, S3 gallop, mitral regurgitation murmurs, and the symptoms that are typical of systolic dysfunction. The diagnosis of dilated cardiomyopathy is based largely on an echo. What would the EKG and the chest X-ray show? The chest X-ray would show an enlarged heart and pulmonary vascular congestion, particularly when there's acute symptoms. The heart can dilate to both sides, but is more likely to be dilating to the left ventricle. The EKG will show a sinus tachycardia and arrhythmias. What arrhythmia? Any arrhythmia, but atrial fibrillation is the most common. Conduction disturbances such as AV block, first degree and second degree AV block happen because as the heart dilates, it stretches the conduction system. The echocardiogram will show a dilated left ventricle, a decreased wall motion, mitral valve regurgitation, aortic regurgitation, because as the heart dilates, the leaflets separate. Cardiac catheterization is still the most accurate test, rarely necessary, and will show a diffuse dilated hypocontractile ventricle and mitral regurgitation. Dilated cardiomyopathy, in order to call it a cardiomyopathy, you have to make sure it's not from dilation just from valve lesions, or from coronary disease, or from hypertension that gets tired and the heart starts to dilate up. By definition, a dilated cardiomyopathy is a heart defect in which the person's valves are not the cause. They are the result of the cardiomyopathy. In other words, mitral regurg causes dilation of cardiomyopathy. Dilated cardiomyopathy also causes mitral regurgitation. So it's a cardiomyopathy when it's a muscle defect. The treatment's similar to the other forms of congestive heart failure. ACE inhibitors, ARBs, beta blockers, spironolactone. Let's get those drugs that lower mortality. The beta blockers that lower mortality is metoprolol, carvedilol, bisoprolol, carvedilol, metoprolol, bisoprolol are the ones that lower mortality. Spironolactone, but I got man boobs. My boobies got big and I didn't like them because they're anti-androgenic. Eplerenone. Spironolactone minus man boobs is eplerenone. Digoxin and diuretics decrease symptoms but don't decrease mortality. When there is a very low ejection fraction, we put an implantable defibrillator in because the most common cause of death in dilated cardiomyopathy is arrhythmia. The next subject is HOCM, hypertrophic obstructive cardiomyopathy. Now this is hereditary in a number of cases, or it can be familial, or it can just happen. You see, it's not as important about the etiology of this one. What would you do differently? Nothing. Now this is more than just thickening of the heart. Sometimes this is called asymmetric septal hypertrophy. See, it's not just that it's enlarged asymmetrically. It's like having one breast at a C cup and the other at a double D. It's not just that it's enlarged asymmetrically, you're going to fall over. And that's what happens here. It ends up having it be that the septum is enlarged asymmetrically and you fall over now, don't you? So it's an asymmetric septal hypertrophy, and that also hits the valve leaflet. And that's where the symptoms come in. The myocardial hypertrophy leads to decreased LV compliance because it's thick, it doesn't relax well, it doesn't fill well. The systolic performance is not decreased, that's why the ejection fraction stays normal. The diastolic dysfunction is characteristic. There's a decreased compliance. It doesn't fill. It doesn't relax. It doesn't fill. It's hypercontractile. The ejection fraction is supraphysiologically abnormally high, 10 and 20 points above a normal ejection fraction. And that's why the left ventricle cavity is completely eliminated, obliterated by the contraction. It empties out, and that's why sometimes when it empties even more, people pass out. Anything that increases emptying makes it worse. Tachycardia, it's more empty, doesn't have time to full, make it worse. Digoxin increases contractility, makes it empty, makes it worse. Beta stimulation, like running around, makes it worse. And PVCs is half empty, makes it worse. Valsalva and standing is emptier, makes it worse. Nitroglycerin is a venous dilator, and what happens is there's less venous return, it makes it worse, and it vasodilates, and nitroglycerin empties it from behind, and vasodilators empty it from in front, and I'm empty, and my heart is so empty I can't stand it. And I pass out. Reducing the afterload or the preload makes it worse. Now, in the same way, beta blockade allows you time to fill. Disopyramide. My goodness, what's disopyramide doing on the slide? Disopyramide is a type 1A antiarrhythmic. It's in the same class as procainamide and quinidine. And we used to use disopyramide as an antiarrhythmic back in the days when we used to convert AFib routinely. But it's a negative inotrope, and we think, gee, will it do something for hypertrophic obstructive cardiomyopathy? It might. It's a negative inotrope. Maybe it'll help it stay more full. Maybe it will. Maybe it will. Maybe it will. Disopyramide. Anything that increases the chamber size, like bradycardia or beta blockades, or squatting or hand grip. Hand grip increases afterload, and less blood is able to get out of the heart, and the chamber size increases. And when there's more blood in the greater chamber sizes, less obstruction. HOCM, most common presentation, is shortness of breath. Angina happens sometimes. Pre-syncope and syncope are less common. Palpitations happen, but so what? Lots of people have palpitations. Doesn't mean you have anything at all. The least common presentation is sudden death. It may be the first thing, but it's the least common. Jugular A waves, as you have atrial systole into a stiff, non-compliant ventricle. And the carotid pulse becomes abnormal, and S4 is any time you have a person with S4 is a sign of atrial systole into a stiff, non-compliant ventricle. You get a systolic murmur because it sounds like aortic stenosis. Aortic stenosis is a diamond-shaped crescendo-decrescendo systolic murmur. And that was why you need the auscultatory maneuvers. When the question says auscultatory maneuvers are the most useful, auscultatory maneuvers are the most useful for diagnosing which valvular disease? Auscultatory maneuvers are most useful for diagnosing the difference between HOCM and aortic stenosis. Auscultatory maneuvers are the most useful for diagnosing the difference between HOCM and aortic stenosis. That's where it's the most useful. The diagnosis is done by echocardiogram. But what does the EKG show? Left ventricular hypertrophy, funny Q waves in V1 through 3. You can get a ventricular arrhythmia because any cardiomyopathy can give you a ventricular arrhythmia because any cardiomyopathy makes abnormalities of the cardiac conduction system. So any of them can cause a ventricular arrhythmia because it's stretching my conduction system. You're stretching my conduction system. Of course you can tickle it into an arrhythmia. Of course, if you don't want my peaches, why are you shaking my tree? And that's because you're stretching my conduction system, and it makes me have abnormally ticklish conduction. It depends on what the presentation is for the treatment. Asymptomatic people need nothing. A little shortness of breath needs a beta blocker, or a calcium blocker, or disopyramide. But a person with syncope needs an implantable defibrillator. A person with a history of sudden death must have an implantable defibrillator right away. Syncope needs an implantable defibrillator. Sudden death needs an implantable defibrillator. And if you put the implantable defibrillator in and they still stay symptomatic, chop out my septum. You can use a catheter. Put a catheter into the heart, inject absolute alcohol, and cause little infarctions and a little liposuction on your cardiac septum. Zap it, man! Septoplasty. And ultimately, if they're on beta blockers or disopyramide, if they have the implantable defibrillator, if you've tried septoplasty and nothing else works, you will crack them open and chop out part of the heart with surgery. That's it for HOCM. Our next section is restrictive cardiomyopathy, which is defined as rigid, non-compliant ventricular walls. It's the least common cause of all the cardiomyopathies. It's caused by sarcoidosis, amyloidosis, hemochromatosis, neoplasms, and radiation fibrosis. It makes it stiff, it does not relax, it does not contract at all, it doesn't move at all, and you pass out, it doesn't move, you don't move, it doesn't contract, it doesn't relax. It just lies there. Restrictive cardiomyopathy, which is very easy for the beginning student to confuse with constrictive pericarditis. Restrictive cardiomyopathy and constrictive pericarditis are easy to confuse because both patients get signs of right heart failure because they both have decreased filling. But restrictive cardiomyopathy is seen on an echocardiogram. You see non-compliant myocardium impeding ventricular filling. You see increased filling pressures from abnormal diastolic dysfunction. Systolic dysfunction results in impaired filling, and it makes a clinical and hemodynamic picture that looks like constrictive pericarditis because blood does not move forward. It looks like you got right heart failure. And because of this lack of forward flow, you get shorter breath and exercise intolerance and increased jugular venous pressure, but back pressure into the right side of the heart doesn't fill. Big liver, big spleen, big hemorrhoids, big ascites, S3 and S4, S3 and S4, S4 from atrial systole to the non-compliant ventricle, and Kussmaul's sign. That's also why it's easy to confuse with constrictive pericarditis, which is the other cause of Kussmaul's sign, jugular venous pressure that increases with inhalation, the Kussmaul's sign. You see on chest x-ray a big heart and pulmonary congestion, but the heart may not enlarge that much in external size. The biggest thing about restrictive cardiomyopathy is an immobility of the myocardium that you may not see an anatomic shape change on an x-ray. It's a functional problem. That's why the EKG shows low voltage, because it's a functional problem. That's why the EKG can show conduction disturbance, because it's a functional problem. And QAs, because it's a functional problem. And you may not see an enlargement in external size. It just may be immobile. The echocardiogram will show thickening of all the cardiac structures, and the ventricles just don't move very much. Cardiac catheterization is the answer to the what is the most accurate diagnostic test? What is square root sign? It's a sign of sudden leveling off of filling pressures. It is a sign where the filling pressures empty, go down sharply, go up sharply, and then boop, it stops. Because all the filling pressures is like they're hitting a wall. What are you going to do to treat this? Well, what are we going to do? Well, nothing. If it's from sarcoid, you treat the sarcoid with steroids. If it's from hemochromatosis, you do phlebotomy, like you do for anybody with hemochromatosis. If it's from fibrosis, you treat with DNR, because there's nothing to do. All you can do is transplant that person.